Welcome, everyone, to Rehab Links Secrets to Success podcast. I'm Lisa Chase, your host, and I would love to welcome Kyle Cook to the show today. Kyle, thanks for joining us.
Thank you for having me, Lisa.
Awesome. So Kyle, I was thinking you and I met. It's been quite a few years. I don't really even remember how many years, but we met, I believe, at a Bookhout Seminars course when you were teaching with Mark.
Yeah, it's hard for me to remember also. I feel like you and I may have met at Michigan State before that.
Yeah.
But that was before we really knew each other. And honestly, that was kind of back in the days where my kids were so young and all I could wait to do is get back to the hotel room and just relax for a little bit instead of kind of going around and, meeting people and building relationships. So it's been, my best guess, around 8 to 10 years when we first met each other.
Yeah. And since then, and I'm excited to kind of talk about your, progression through, teaching, but you've also joined the faculty at Michigan State, and you and I have, are starting to teach together. So that's also exciting. But, why don't you go ahead and give our listeners a little bit of a background about you and, kind of what you're doing now. And and we can jump in.
Sure. So I'm a physical therapist. I currently work and live in the Chicago suburbs. I work at Loyola Medical Center, where I'm involved with their residency program, seeing patients, obviously, and then trying to produce some research supporting what we do and what we teach at Michigan State and what we teach at Bookhout Seminars. As you said, I also teach at Michigan State. I've been clinical faculty for, I think, 4 years now. And that's been really rewarding. I've really enjoyed my time with Dr. DeStefano there. I think she's a wealth of knowledge with both clinical knowledge as well as making me a better educator. And then I guess the last thing I do and what we're here to talk about is Bookhout Seminars. For those of you that aren't familiar with Bookhout Seminars, it's developed based on the work of Mark Bookhout, the namesake. And Mark is well known for his time with Michigan State as well. He started taking courses there in the 80s, and before they knew it, they couldn't get rid of him. He took every course he could and started teaching with them, and develop some techniques that they teach now as part of their core manual therapy curriculum, and even the exercise as an adjunct to manual medicine. And so that's really what he's, I would say, best known for. However, what I've always been most impressed with is his search for new knowledge all the time. Even his last years of his career, he's taken 4 or 5 courses a year. In his heyday, I would say more towards 8 to 10.
Yep.
And instead of getting caught up in which philosophy is the best, or I'm more Maitland, or this is certainly a McKenzie patient, his best skill, in my opinion, was taking all those competing approaches and seeing what they're getting at and seeing how they could all be used together. Because you don't have a McKenzie patient or a Mulligan patient or a visceral patient. The rules should kind of follow each other. Maybe somebody's needs are more in one avenue than the other, but the more you can integrate these approaches, the better chance you have at success. And so with Bookhout Seminars, really our base, our core knowledge is the biomechanical model, like taught at Michigan State. Then we go into more secondary courses where we get more integrative, where we bring in the myofascial release techniques taught by multiple different practitioners and approaches, some different neurodynamic techniques, motor control. So we get much more integrative with it, which is where we really start to differ from some of the more traditional education that he had started with. So Bookhout Seminars primarily is right now traveling to other clinics where we're being hosted and really across the country. Mark lived and practiced in Minnesota, so we got a lot of courses in there. But since I'm in Chicago and near some big airports, I tend to fly around to Atlanta, Baltimore. I was just in Minot, North Dakota. So we've been running around teaching this information really across the country.
So talk a little bit about your clinical practice with Mark, right? So both you and Galen, who have kind of taken over Bookhout Seminars and are the main instructors now, had the privilege to work side by side with Mark. And you know, if anybody knows Mark, I mean, I actually spent a week with Mark in clinical practice, and I think that gives you a whole nother perspective of the kind of the magic of how he pulls all these pieces together and approaches a patient. Talk a little bit about that.
Well, I'll backtrack a little bit first. So where I came from was I went to school at University of Wisconsin-Madison. I left school, started practicing in the Minneapolis area, and I felt really underprepared, or felt like I was seeing all these patients that I didn't have the tools or the knowledge base on how to treat. The standard treat what you find education that you get in school wasn't cutting it. So I went back to University of Wisconsin and did their residency program, and that was run by Bill Boysenalt. And he and Mark are good friends, and he too is kind of a mutt. So that program was really focused on getting us tools via Maitland, high velocity, muscle energy, McKenzie. And I did very well. I had a paper that was being published in JOSPT. I was really good at these skills. So Bill told me I should go meet his friend Mark. So I did. And Mark sat there and basically listened to me tell him how lucky you'd be to hire me for about an hour and a half. And I really thought I had it figured out. And then I started working with him, and to build my practice, I'd spend a lot of time watching him treat and asking him questions and things like that. And I'd see that he's doing all this myofascial release and craniosacral therapy and different ways to demobilize the nervous system. And he'd offer to show me things. And at first it was kind of like, no, I think I'm doing okay. You know, I thought that I had it all figured out. And then patient after patient that I struggled with, I would see with him, and sometimes just a couple visits, it'd be so dramatically different.
Yeah.
And so I thought, even though I'm such a wonderful clinician, I need to start learning these things. And so, because at first, I mean, visceral manipulation, craniosacral is just too alternative for me. But what Mark would do is, mostly through the Brawl Institute, use listening as a way to identify the primary restriction in that individual's body. For you that aren't familiar with that term, that's this idea in the osteopathic philosophy that your body has kind of a key restriction, and you got to find a way to get at that. You know, with that whole idea of treat what you find, you don't know if you're treating something that's really key or something that's more compensatory.
Yes.
And when we get into, especially our later classes, we have some comprehensive approach to the pelvis, the thorax, or even our myofascial course. We really get into some techniques where it's trying to find, where do we need to start? I just had a woman that had this awful sciatic pain. She'd had injections. She had, I think I'm fifth therapist, chiropractor, no relief. My listening, my postural loading told me to left upper quadrant. I started asking her more questions, and she actually has a long history of thoracic outlet syndrome that was never resolved. And addressing that region released the nervous system, neurodynamics, and then within 6, 8 visits, her hamstring pain was gone. And
Yeah.
so if I would have kept chasing her hamstring pain, how would I have been any different than everybody else that she had seen before, or I guess sciatic pain? So, sorry, getting back on track with Mark.
Yeah.
Uh, he would use the listening. He would go through his biomechanical screen, looking at the joint mobility based on Michigan State, and try to piece together the puzzle, identifying mostly the primary restriction, but also what's feeding into that and what else needs to be addressed with that. That was really some of the most exciting and where some of the years I had the most professional growth, sitting right next to him every day, asking questions, and he treated me, I treated him, me watching him treat patient after patient. It was really a great learning experience for me.
Yeah, I mean, I think that's a gift, to be able to have worked side by side, to work on him, to work with him, have him work on you, yeah, it really helps you grow as a clinician. And I think, a lot of therapists that come out of school or go through some kind of a residency, right? We think we have it all, figured out. But then when you get in front of a clinician like Mark, and obviously like Carl and Lisa, that we work with at Michigan State, and, that you're just like, okay, I want to be like them. Right. And you got to be a lifetime learner. You got to just want to seek and want to know more. And, so I'm so great that, I think it's so great that you guys are carrying on Mark's work, as, I'm trying to do with the exercise course and some of the things we're doing with Rehab Links. So with that, why don't we jump into your top 3 tips on how to get the best clinical outcomes, right? Because at the end of the day, that's what patients come to us for, right? They want to get better. They want to get out of pain. And, talk a bit about, your experience and what you think those top tips are.
Yeah, I spent some time thinking about that. My clinical practice is what's helped me the most. Honestly, the best tip I ever heard probably came from Carl Steele. And he told me, to make this model work, you have to be brutally honest.
Mm.
You have to do your technique, reassess. Did you change that FRS? Check their range of motion. Can they stand? Can they bend better? And if they can't, what could you do better? You can't just be satisfied that, oh, there's an FRS, I treated it, how great am I? You have to look and see if you truly made a change. And if you didn't, what do you need to do better? Do you need to get better at your technique? Are you not getting at the source of that joint restriction? One of the things we have to be aware of is we're so, as a profession, joint based. It's joint. I think sometimes the joints are a reflection of either some kind of dural or fascial restriction. And if you keep treating that joint and it's not changing, you're going to keep chasing that joint and not help your patient at all. So be honest with yourself, be critical about what you're doing and the effects it's having. And you don't know that unless you look. So taking that extra moment to reassess makes a huge difference.
Well, and let me piggyback on that, because, Carl's definitely one of my mentors, and certainly that is one thing he has taught me. And the other thing that he's taught me is, if it doesn't change, you should have, as a clinician, especially the more experienced you are, you start to get an appreciation for how the tissue should respond to what you're doing. And if it doesn't respond the way the musculoskeletal system should respond, or it gets worse, which I've seen happen, then that's a red flag, and that's a timeout, right? That's a time to say, you know what, I'm not sure that what we're doing is for you. I think we need further investigations. I've caught things, I'm sure as you have, whether it be cancers or other things that are going on in the system that is coming out in the musculoskeletal system. But when it doesn't change, so really listening and being honest, I think that's a great point.
The second one, I think Mark really piggybacked off of the work of Thomas Myers on. And again, it's really focused. I don't know, maybe it's just my own personality. I focus on myself. What could I do better? What can I change? But it's really about self-reflection as well, and looking at the major domains of what we need to be able to interact with as a manual therapist. And Thomas Myers used some different words, but it's really, we have to have good techniques to mobilize the joints. So that can be Maitland, high velocity, muscle energy. In my opinion, all those techniques are along the same continuum. They're all different ways to help the joints move better. And so, when I evaluate research, no matter what technique they're doing, I kind of put that in the same bucket of ways to get the joints to move better and the effects that they can have. Then we have the myofascial system, so the system covering the muscles and I would say even the periosteum, the visceral fascia, and then the dural system, neurodynamics, and finally motor control. And so when you look at those, you should think to yourself, what am I strong at and what do I need to get better at? And challenge yourself to find ways to get better at those weak areas. Mark felt really insufficient at the myofascial piece of things towards the end of his career. And I think during the last 5 years of his career, he took 40 courses almost.
Yeah.
For me, a few years ago, I felt like I could be doing better with my core stability. And the more I talked to these pelvic floor therapists, the more I realized they really have a better handle on it than most of the rest of us. So I pursued coursework from Diane Lee, Julie Weed, and actually the one that I haven't been able to get to yet is right in my back door, Mary Massery. And so I thought that was a weakness, and so I pursued ways to get better. And so in the clinic, I am constantly asking myself, how can I do things better and where can I find that information? I'd like to share one piece of advice that Mark gave me talking about this podcast coming up. And he, in his 35 years of practice, has found muscle energy to be the most effective way to get the joints moving.
Yeah.
And to tell you the truth, I might dabble more in high velocity depending on what mood I'm in. There's some approaches where you can do joint mobilization as more as a myofascial release technique. But if I'm honest with myself, the good old muscle energy technique just gets it done better. So
100%. Yeah. I mean, I remember sitting across from Mark, we were having lunch or dinner, and I said, okay, because every time we would get together, I'm like, all right, what courses are you taking and what are you learning and what do I need to know? And I remember sitting across from him and I said, Mark, out of all the courses, everything that you've learned, what do you think is the one game changer that if you only had one skill you could use, what would it be? It was always muscle energy.
always muscle energy.
Always muscle energy.
And again, the biomechanical approach is a great base.
Yeah.
It's a foundation that we do all these other techniques based off of. And that's really how Bookhout Seminars is organized, is that way where you get the foundation with muscle energy, and then you learn all these supportive techniques.
Yeah.
Because Mark would always say, you have to find a way to enter the system.
Yeah.
And he'd say that to me. It sounded like a bunch of jargon, and I couldn't quite gather what he was getting at. And the more I practice, the more I see that really we are very neuroreflexive. When we have any kind of pain or altered joint mechanics stimulating the mechanoreceptors, it changes how we move.
Yeah.
And we need to find a way to change that input into the dorsal columns of the spinal cord. And whether it's Maitland, whether it's Baral's direct neural releases, visceral manipulation, you have to find a way to allow the patient to move without that nociceptive input knocking out the muscles. And this sounds so theoretic, but there's more and more research that supports this.
Yeah.
John Lieber was probably one of the first people that published using diagnostic ultrasound, and he showed you getting more extension in the mid-thoracic spine helped the lower traps.
There
Josh
you
Cleveland
go.
went and did that using manipulation.
Yep.
Now we have it in the lumbar spine. Copenhaver did it in JOSPT, where he showed patients that fit the clinical prediction rule. If you manipulate them, their girth of their multifidi get better in the responders, and the people that didn't respond, it doesn't change.
Yeah.
And it goes to SI joint, people with knee pain, it goes on and on and on. So we have to find a way to facilitate more normal movement.
Yes.
You know, we talk about all these different manual therapy techniques, but the goal is to get the barriers out of the way to restore normal function for the patient.
Yeah.
From a motor control and a body mechanic standpoint.
Yeah, absolutely. Definitely. I definitely can echo that, I mean, getting the nervous system to, to do what it needs to do so people can move, getting muscles to activate or other muscles to calm down is really the key. And obviously once you make that neural change, you talked about motor control, and that's, I think, a really important piece. And that's what I love about the exercise course, and how Mark married, okay, this is restricted, these muscles are over or under firing. Why is that? What do I need to do to make a change at that level? And then how can I give the most effective exercise that is going to maintain and allow me to continue to progress this person faster? And Mark was just, a master at being able to kind of pull all those pieces together.
Yeah, I often hear him in my ear saying, we need to be just as skilled with our exercise prescription as our manual therapy.
Oh, yeah.
And I try to emulate that as much as possible in the clinic.
Yeah.
I hate when I inherit a patient with 45 exercises listed. The
Yeah.
patient doesn't know what they're doing. I don't know what they're doing. Nothing's getting done. Mark was so skilled at just targeting those couple things that you need to work on to allow you to basically get on with your life.
Yeah, that is so true. I know people do come in with, pages and pages of exercise, and then they just get overwhelmed. And, and then, therapists are like, oh, well, you're not doing your home program. It's like, well, you have to meet the patient where they're at. Well, why aren't they doing their home program? Why? Because they're overwhelmed with the amount of exercises that we've given them. So narrowing it down to just the few and going, okay, or each day, I want you to do this on Monday, this on Tuesday. You just have to find, where that person's at, why they're not, being compliant. They're not being compliant, not because they don't want to, but usually it's because, we haven't really listened to the patient, and we're not prescribing exactly what they need to do to be most effective.
Well, and that's one of the benefits of your exercise program as well, is you can take away the exercise, add the exercise, so they always have a nice running list of what they're expected to do. I think confusion really starts to interfere with compliance with the exercise program. So being as clear on your expectations with them as possible is really key.
Yeah, I think that's great. Okay, well, those are great tips. Now, I want you to think a little bit about now you as an instructor at Bookhout, seminars, and what are like 1 to 2 things that you can share with our audience that you hear all the time that your audience appreciates, your students or your patients really appreciate?
Well, Bookhout Seminars is very, very focused on the anatomy and different anatomic relationships. And that's how we can take some of these more alternative philosophies like craniosacral therapy, visceral manipulation, and bring it more into a streamlined approach. For example, if you're having a problem at the thoracolumbar junction and you treat it and it's just not getting better, knowing that there's strong ties in from the fascia covering the quadratus lumborum, the hip flexors, topping off at the arcuate ligament. Those are all potentially soft tissue restrictions that could be feeding into that thoracolumbar junction dysfunction that you're not getting at. It could even be breathing, at the diaphragm attachment there. All of those are so intimately connected from a fascial perspective. Knowing that all that's tied in that area, it can give you some other things to start assessing or working on as a way to free up that key area. Other examples would be, if someone's got pubic symphysis dysfunction and you treat it and you have to do the shotgun technique every time you see them. Well, if you go in and actually assess it and you can feel on one side there's rectus tone there, that might bring you up to T5 to 7 where it attaches to the lower ribs. And I say most of the time, then you go and find some FRS dysfunction in that neighborhood. I'm more surprised when it's not there versus when it is. And so being able to talk through not just the model, but then, all right, if you can't get this, look at these things. If you can't correct the sacral dysfunction, well, Carl Seal would make sure you got that longissimus tone knocked out. That oftentimes starts in the mid to lower thoracic spine. So in our courses, we go through the biomechanical model, but then through the depth of anatomy review, we really try to make all the connections so you can have a plan B and a plan C. The other thing that we get good feedback from in our courses is just how we keep trying to integrate these different approaches and learning new techniques and tying it all together. I really try to resist the urge of staying static. Our information is always evolving based on the newest literature and different techniques that are out there. I pray that we haven't topped out with our knowledge on how to treat the human body. And so as we learn more, we should adapt more. That being said, with the push for evidence-based practice, we've been adding more and more research to our slides. And what's remarkable to me is I spend most of the time reviewing PubMed and other journals, but we don't have to change our curriculum. It's amazing how much the research that keeps coming out supports
it.
What they've been doing for 30 plus years.
Right. Yeah.
So those are the things I hear most often that are complementary to the Bookhout Seminars approach.
Yeah, and I would echo that. I remember when I first started teaching with Mark, I was thinking, oh my God, how am I ever going to keep up with Mark? Every slide he was quoting, all this literature. So, I think Mark was always looking at the literature and how it could pair with what was being done. So that's great that you're going to continue to carry that on. But yeah, I think that's great. Okay, so is there anything else of value that you would like to give our listeners? And then how can our listeners find you?
Yeah, so as something of value, we are willing or prepared to give a discount to our next hosted Bookhout Seminars course. And so that's a course that we're hosting. So we can't go and give discounts if you're going to go to somebody else's clinic, but we're working on scheduling some courses in the Minneapolis area. And if you just mention with your registration that we would like to have the podcast discount, we'll give you $100 off your tuition.
Wow, that's excellent.
Yeah, it's and honestly, for a 3-day course, compared to a lot of other places that we compare to, we're pretty cheap, and so adding another $100 to that makes it quite affordable. You can find us at bookhoutseminars@gmail.com. That's the best way to email us directly. We have a website at bookhoutseminars.com. On there, we have some information about our philosophies, our current course schedule, and some literature up there that supports our approach. We're on Facebook, on LinkedIn. You can just search Bookhout Seminars for those. We have course announcements primarily on that, but every once in a while we'll have some clinical pearls that we will post as well.
Excellent. Well, I can't say enough about, you know, the content and the quality of those courses. They were, you know, especially as you get to be, you know, a clinician of experience, you're always looking for, okay, like I really want to take a course that's going to make an impact on my clinical practice. And you will not be disappointed if you go to take a Bookhout Seminars course. They're excellent, and I would absolutely highly recommend them. So, well, I appreciate you coming on today. Thanks so much for taking the time. I know you're super busy with your family and your work. So I appreciate it. And until next time, keep getting good clinical outcomes.
Thank you, Lisa.